Welcome to Concise Approach to Internal Medicine. My name is Guillermo Garcia. I am an internal medicine physician, and today we will answer the question, in which hospitalized patients should thromboprophylaxis be performed? To begin, we must ask ourselves two other questions. The first is, does the patient have a surgical or medical pathology? The answer is important because it involves a different approach to thromboembolic disease risk. And the second, what is the risk of thromboembolic disease? The risk of thromboembolic disease is classified as high and moderate, indicating that pharmacological thromboprophylaxis should be used. If it is classified as low risk, it indicates that no intervention should be performed on patients. When the patient has a surgical disease, high risk is defined when requires major orthopedic surgery, arthroplasty, or recent fracture, abdominal pelvic cancer undergoing surgery, has a recent spinal cord injury or major trauma within 90 days. High risk is also classified if the patient has more than 3 intermediate risk factors. What are the intermediate risk factors? Not ambulating independently outside of room at least 2 times a day, have active infectious or inflammatory processes, active malignancy, major surgery, non-orthopedic, history of venous thromboembolism, stroke, central or peripheral venous access, inflammatory bowel disease, paresthesia, prior immobilization more than 72 hours preoperatively, obesity with a body mass index greater than 30, patient age over 50 years, hormone replacement or use of oral contraceptives, hypercoagulable state, nephrotic syndrome, burns, cellulitis, varicose veins, heart failure, or exacerbation of chronic obstructive pulmonary disease. The patients in a low-risk surgical setting are defined with minor procedures and age under 40 years without additional risk factors, and ambulatory with expected length of stay of less than 24 hours or minor surgery. In patients with medical pathology, what is the risk of thromboembolic disease? To establish the risk, the Padua and Caprini scores are used. The Padua score contains the following variables: active cancer, previous deep venous thrombosis, reduced mobility, thrombophilia. The previous features score 3 points each. Surgery or recent trauma in less than a month scores 2 points. And age over 70 years, heart or respiratory failure, acute myocardial infarction or stroke, acute infection or rheumatic disease, obesity with a body mass index of 30, hormone treatment in progress. The above scores 1 point each. To clarify, active cancer, it also includes patients with distant or local metastases or who have undergone radiotherapy or chemotherapy in the last 6 months. Reduced mobility is considered bed rest due to limitation of the patient or by medical order for at least 3 days. Thrombophilias are considered in carriers of defects such as antiphospholipid syndrome, prothrombin deficiency, protein CNS deficiency, factor V latent and prothrombin mutation. All patients with a score greater than or equal to 4 connotes high thromboembolic risk and should be treated with thromboprophylaxis. The PADO scale is applied in non-critical patients. The Caprini score is a much more elaborated scale that contains variables that award 1, 2, 3, or 5 points. It is a more cumbersome scale than the PADO scale, and when the patients have 3 or 4 points, it has a moderate risk, or more than 5 high risk. In these patients, thromboprophylaxis should be indicated. When comparing the Padua and Caprini scores, like in this study, the performance is much better with the Caprini score. However, the Padua score is much shorter and more practical, so it is preferred in most hospitals. In conclusion, the Padua score indicates the start of thromboprophylaxis in non-critical patients with medical pathologies, and it's easy to use, while the Caprini score shows better performance compared to the Padua score. it has more complex applicability and requires more validation studies. It's important to clarify that the Caprini score is also used to define high risk in surgical patients. The following is the bibliography used to answer the question. Thank you so much. Don't forget to subscribe, like the video, and share it.